We'll first begin with Andrea, perhaps, and just a brief overview of what are the indications for treatment. All patients in need with hairy cell leukemia need therapy. Can some of them be observed with the monitoring alone?
It's not curable, and most patients will relapse at some point. And so you don't necessarily need to treat right away. And so there are kind of three big reasons to treat. One would be significant cytopenias. So if you have a neutrophil count that's less than 1,000, if your hemoglobin is less than 11 grams per deciliter, if your platelet count is less than 100,000 microliters, those are all indications that the hairy cell is causing significant issues and that you're at higher risk for things like infection. If you're having symptomatic splenomegaly or other symptomatic adenopathy, again, lymph nodes are not the most common thing, but certainly do occur. And then certainly constitutional symptoms, if they are significantly impairing activities of daily living, those could all be reasons to treat.
Then Dr. Saban, then perhaps you can start us off by some of the first-line therapy options for patients with hairy cell leukemia. I know we talked about some pure analog, and there are a couple choices there. And when would you choose one versus another? And perhaps a little bit about your schedules and how is it given route of administrations. And obviously, other panelists can also chime in afterwards too.
I think most people would agree that in ideal circumstances, that purinucleoside analog is the treatment of choice. And you've got two real choices. One's Cladribine or 2-chloro-deoxyadenosine, and the other is Pentostatin. Cladribine historically was given as a single week of infusion. There was in vitro data showing that prolonged exposure was better than brief exposure, hence the continuous infusion for a week. And it was 0.1 milligram per kilogram per day by continuous infusion for 7 days. Ultimately, that became a bit of a hardship because people needed a catheter and a PIC, and the catheter got infected. So we converted to 0.14 milligram per kilogram per day over 7 days, over 2 hours for 5 days, and that represents 0.14 milligrams per kilogram over 2 hours each day. And there hasn't been a direct comparison, but if you look at the results, they're almost identical. So we tend to give it now as a 2-hour infusion over 5 days, and it's one cycle of therapy. We give it intravenously, but there are preparations in which you can give it subcutaneously. And years ago, we did a PK study showing that you can actually give it orally. So if you double the dose and give it orally, you can achieve the same levels. But at Scripps in 2020, we give it as a 2-hour infusion times 5 days. Pentostatin is another treatment available as first-line therapy. It's given every other week, 4 milligrams per meter squared IV, but it's much more protracted therapy. It's given every other week and for 3 to 6 months. So not surprisingly, Cladribine, because of its convenience, has emerged as the treatment of choice. I think we wisely, at the beginning of our studies, under the direction of Ernest Beutler, said, we're going to exclude actively infected patients. So we appreciated the immunosuppression of this drug, and people had to have the infections treated before they started. I think the people who championed Pentostatin initially didn't have that exclusion, and you could receive the drug on their studies. But I still wouldn't use either purinucleoside analog in the presence of active infection. There's been a number of publications, including from Dr. Ravandi, about whether you can combine Cladribine with anti-CD20 Rituximab. The way Dr. Ravandi did it was you give the Cladribine, you wait a month, and then you give 8 weekly doses of Rituximab. Kreitman from the NCI has given it on day 1 and then day weekly times 8. Together with the 5 initial doses of the Cladribine, and you can achieve a deeper level of response, i.e. lower minimal residual rates. Whether that's clinically important or not, and whether it's worth the extra immunosuppression that's going to follow is a subject of debate. Now in the age of coronavirus and the fears about immunosuppression, and if you elect to use a purinucleoside analog, you may or may not want to add the rituximab given the more prolonged immunosuppression that is likely to follow. Interferon, the magic drug that was on the cover of Life magazine many years ago, actually was approved to treat hairy cell leukemia, subsequently had other uses. I haven't used interferon for many decades, but there is a role for it, probably in actively infected patients. If you can get hold of vemurafenib, a BRAF inhibitor, maybe a role for interferon. If you have a pregnant patient and is not a candidate for splenectomy in the second trimester, maybe there's a role for interferon. But the remissions from interferon are not very deep. Most of them are partial remissions, take protracted therapy over the course of a year, self-injections of a medication. So it's not commonly used anymore. Also, if you use interferon after a purine nucleoside analog, it's very unlikely to work. Other safety concerns, not really. Blood counts may get worse before they get better. And with Cladribine, it has about a 40% incidence of neutropenic fever. But despite the incidence of neutropenia, at least at Scripps, we've seen rare infections. So that's how I approach new patients with hairy cell leukemia. There's emerging data about the role of vemurafenib as frontline therapy. I think Dr. Parker's studies at Memorial Sloan Kettering in combination with obinutuzumab, but I think that's in the realms of research rather than standard of care. But in the day of coronavirus, where you don't want to immunocompromise patients, that is a consideration.